Hello and welcome to this presentation on prostate diseases. My name is Tara Burnhope. I'm a urology registrar at Birmingham City Hospital, and we also have Mr. Danasakaran, who's a consultant urologist and the educational lead for urology. Today we're going to talk about the prostate, what it is and what it does, its anatomy, and then we'll discuss three key diseases of the prostate: benign prostatic enlargement, where we'll look at lower urinary tract symptoms and touch upon urinary retention, and we'll also look at prostatitis and prostate cancer. So firstly, what is the prostate? It's a small walnut-sized gland found in men, and it sits just below the bladder and surrounds the urethra. It produces and secretes fluid which nourishes sperm as it's ejaculated during male orgasm, and contains proteolytic enzymes, prostatic acid phosphatase, fibrinolysin, zinc, and PSA, or prostate-specific antigen. This is a protein which can be detected in the blood, and we use it for diagnosis and monitoring of various diseases. The seminal vesicles also contribute fluid to the ejaculate. We'll see that on the next slide. And together this forms semen, which is transmitted into the urethra via the ejaculatory ducts, which are two tiny holes, one either side of the midline of the prostatic urethra. This diagram nicely illustrates the relation of the prostate to other genitourinary structures. You can see one of the two seminal vesicles which sit just above, behind and lateral to the prostate, and you can also see how closely related the gland is to the lower part of the rectum, and that's why we're able to examine the prostate via. This diagram nicely illustrates the relation of the prostate to other genitourinary structures. You can see one of the two seminal vesicles which sit just above, behind and lateral to the prostate, and you can also see how closely related the gland is to the lower part of the rectum, and that's why This diagram nicely illustrates the relation of the prostate to other genitourinary structures. You can see one of the two seminal vesicles which sit just above, behind and lateral to the prostate, and you can also see how closely related the gland is to the lower part of the rectum, and that's why we're able to. Macroscopically, we can also divide the prostate into 5 lobes: the anterior, posterior, median, and 2 lateral lobes. This is commonly referred to during transurethral procedures. Macroscopically, we can also divide the prostate into 5 lobes: the anterior, posterior, median, and 2 lateral lobes. This is commonly referred to during transurethral procedures. So here we have a view from a cystoscope sat in the prostatic urethra. In the pictures on the left, you can see that the lateral lobes are enlarged and are meeting in the middle, causing some obstruction of the urethra. In the top right picture, the lateral lobes are less obstructing, and just beyond that you can see an enlarged median lobe. In the bottom right picture, microscopically we can divide the prostate into 4 zones, which were described by McNeil. I wouldn't get bogged down with the percentages here, but it's really for you to appreciate where the different zones are, and that the majority of prostate cancers are in the peripheral zone, whereas BPH originates in the transitional zone. That's quite a common MCQ question. Okay, so we're going to move on to 3 common prostate diseases now. Just a note, first of all, that remember when anyone asks you about diseases of an organ, it's important to have a system, a surgical sieve. It shows that you're a methodical and systematic thinker, which is what examiners are looking for, and what your bosses and seniors will be looking for when you're on the ward as well. So vitamin D is the one that I use. So benign prostatic enlargement is extremely common, and no matter what specialty you go into, you will all see patients that have this disease at some point in your career. It's caused by a benign increase in the number of epithelial and stromal cells in the transition zone, and it is a clinical diagnosis. So the diagnosis is made by a combination of your history, examination findings, and investigations such as uroflowmetry and imaging. Benign prostatic hyperplasia is a histological diagnosis, on the other hand. So although benign prostatic enlargement is the sort of clinical manifestation of the hyperplasia, which is the histology and the cause, you can't, strictly speaking, say that a patient has BPH unless it's proven at a biopsy. The patient's symptoms aren't always proportional to the degree of enlargement or the size of the gland, and they might present with urinary retention in the acute setting as well. Lower urinary tract symptoms, or LUTS, will form the basis of your general urological history taking. You may have heard these symptoms referred to as prostatism, which is an outdated and misleading term that we don't use anymore. And the reason for that is because these symptoms don't necessarily pertain just to the prostate, and you can have pathology of, for example, the bladder or the urethra, which can cause the same or similar symptoms. We can categorise them into storage and voiding symptoms, as you can see here, and it's quite a lot to ask the patient. And certainly I used to find it difficult to remember all of this when I was a student. So if you do find that difficult, try and think through chronologically what happens when you go for a wee. So think about the symptoms that you might get beforehand, what happens during your void, and symptoms that you can get afterwards, just to make sure you're not missing anything. It's important to establish the duration of the symptoms and also how much it's bothering the patient, because ultimately that is what is going to determine how you intervene for these patients. I've highlighted hematuria here because that's a red flag symptom, and that should alert you that there might be a malignant process going on. In terms of investigations, you have to take each patient individually, but these are the sort of tests that we would consider. Uroflowmetry is where we ask the patient to void into a funnel with a uroflow meter attached, and this plots the volume of urine as it comes out and the time taken and provides us with a graph. This commonly comes up in MCQ questions, where they might ask you to label the axes or state which one is a normal flow, which one is suggests BPE or a urethral stricture. So all this information is here for you. With BPE, it takes the patients longer to achieve their maximal flow rate, and their maximal flow is reduced. It also tends to tail off quite slowly, so the overall void is prolonged. The medical management of BPE is quite straightforward. There's just two categories of medication for you to learn about. The first are the alpha blockers. Most commonly, we use tamsulosin, 400 micrograms once a day, and this works by relaxing the smooth muscle in the prostate and the bladder neck to relieve the patient's obstructive symptoms. It works quite quickly, takes hours to days, but the full effect can be seen within a few weeks. Most men will experience retrograde ejaculation, where instead of ejaculating forwards and out through the urethra, the ejaculate drops back into the bladder. This isn't painful, it's not associated with any complications, but it does take some getting used to, so it's an important counselling point. Patients may notice that their first urination after ejaculation can be quite cloudy as a result, and again that won't do them any harm, but it's important to reassure them about this. Postural hypotension and dizziness is common, So we ask patients to take their medication before bed so that they're lying down, and to take their time getting up from sitting or lying. We must be cautious in patients who are a high falls risk, and often our patients are quite elderly, comorbid, they can be frail, and they can be on a lot of other medication that predisposes them to falls. So it's an important consideration, especially for those who are also anticoagulated, as the repercussions for those patients of falling can potentially be quite severe. Floppy iris syndrome is a very niche side effect, so that often crops up in MCQs. Essentially, if you're on tamsulosin and you're going for cataract surgery, it's important that The next group are the 5-alpha reductase inhibitors. So we commonly use finasteride 5 mg once a day. This works by inhibiting the conversion of testosterone to its more potent form, dihydrotestosterone, and that is what drives the hyperplasia. The side effects tend to be sexual, erectile dysfunction, reduced sex drive, ejaculatory problems. A small percentage of men may develop gynecomastia, bilateral breast swelling, and that doesn't resolve with stopping the medication. It takes quite a long time to work, 6 weeks to 6 months, so it's important that the patients are aware of that and that their expectations are realistic. During this time, however, the medication is working on a cellular level to shrink the gland and reduce. The next group are the 5-alpha reductase inhibitors. So we commonly use finasteride 5 mg once a day. This works by inhibiting the conversion of testosterone to its more potent form, dihydrotestosterone, and that is what drives the hyperplasia. It's worth bearing in mind that not all men want or require treatment, and like anything, it's a balance of what side effects are they willing to put up with and how much are their symptoms bothering them. So it's really important to establish that in your history taking. It's proven that combination therapy, so tamsulosin and finasteride, is more effective than monotherapy, as you get the symptomatic and more immediate relief from the alpha blocker and the more chronic benefits from the finasteride. Failing that, we're looking at surgical management for the prostate, and this has changed enormously over the past 5 years even. New procedures are coming out that are more minimally invasive and have a lower side effect profile. The traditional procedure is the TURP, which is performed under a general or a spinal anaesthetic. And we go in with a resectoscope, which is similar to a cystoscope. And we have a cutting loop that has a current going through it, and we gradually chip away at the prostate from the inside or bore it out. We often describe it to patients in that way. So if you remember that slide right at the beginning where we looked at the lobes that were occluding, we'd gradually sort of nibble away at that so that we're left with very minimal prostate and just the prostatic capsule beyond it. Benign prostatic enlargement can present as acute urinary retention, which is the acute and painful inability to pass urine, which is relieved by insertion of a catheter. This latter part is really important. If your patient is still in pain after catheterization, then you need to look for other causes. In particular, you don't want to miss something like a leaking abdominal aortic aneurysm. You can also have chronic urinary retention, where the bladder over a long period of time has been adapting to a distal obstruction, such as from BPE, so there's usually a preceding history of LUTS. Over time, the bladder stretches and its capacity increases, so as a result, chronic retention is often painless and associated with large residual volumes, which can be litres and litres. Benign prostatic enlargement can present as acute urinary retention, which is the acute and painful inability to pass urine, which is relieved by insertion of a catheter. This latter part is really important. If your patient is still in pain after catheterization, then you need to look for other causes. In particular, benign prostatic enlargement can present as acute urinary retention, which is the acute and painful inability to pass urine, which is relieved by insertion of a catheter. This latter part is really important. If your patient is still in pain after catheterization, then you need to look for other causes. In particular, you don't want to miss something like a leaking abdominal aortic aneurysm. You can also have chronic urinary retention, where the bladder over a long period of time has been adapting to a distal obstruction, such as from BPE, so there's usually a preceding history of LUTS. Over time, the bladder stretches and its capacity increases, so as a result, chronic retention is often painless and associated with large residual volumes, which can be litres. I've included this slide just as a reminder that there are lots of other different causes of urinary retention, and BPE is just one of these. An important one to always consider, especially in younger patients, is Cauda-Equina syndrome. Features that should raise your suspicion of this are lower back pain, lower limb neurology or saddle anaesthesia, and this should prompt you to perform a full neurological examination. Prostate cancer can present as retention as well, so inquire about weight loss, bony pain, and which may indicate advanced disease, and hematuria again should alert you to potential malignancy of the urinary tract. Nocturnal bedwetting is essentially an overflow incontinence, which is indicative of high pressure chronic retention. Once the patient has been catheterized, you want to assess whether their pain and abdominal swelling has resolved, and if not, as I mentioned, you need to look for other pathology. A digital rectal examination must always be performed to assess the prostate for size, features of malignancy or infection, which we'll come on to later. The patient may be constipated, and that could be the cause of their retention, and you may want to assess the anal tone and saddle anaesthesia. Investigations will include testing the urine for infection and baseline bloods, full blood count, urea and electrolytes, and you may consider a CRP if infection is a likely cause. Once your patient's been catheterized, the urine output should be documented hourly to assess for a post-obstructive diuresis. This occurs in high-pressure chronic retention, and it's because of renal tubular dysfunction and inappropriate salt and water handling by the kidney. Patients can become very dehydrated from their diuresis and hyponatremic if this is left ignored. As a general rule, if the patient voids more than 150 ml per hour over 2 consecutive hours, then over the following hour they should receive normal saline intravenously for half of that volume. So for example, if they've diuresed 300 ml over an hour, then the next hour they should receive 150 ml of normal saline IV. In men with suspected BPE who do not have high pressure chronic retention, they can be started on tamsulosin and their catheter removed in 1 to 2 weeks. If they have high pressure chronic retention, then their catheter must not be removed and they need a plan in place for definitive management. So their options are either a long-term catheter, if the patient is elderly or comorbid, for example, intermittent self-catheterization, where we teach the patient to pass a catheter themselves to drain their bladder, or surgery such as a TURP to debulk the prostate. So the take-home messages for BPE are that it is very common. Symptoms can have a significant impact on a patient's quality of life, so it's very important to manage their expectations and their concerns. And please always document the residual volume after you've catheterized a patient, as this has a bearing on their subsequent management. Moving on to prostatitis. So this is inflammation of the prostate, usually caused by infection. It's uncommon that the causative pathogen is detected, but most commonly it's an E. coli in acute infections. Symptoms for greater than 3 months suggests chronic prostatitis, which has a wider spectrum of pathogens. And of course, if the patient is immunosuppressed, then they're more likely to be infected with things like tuberculosis or fungal infections. Risk factors are anything that can introduce infection in that area, so UTI, urethral instrumentation, and reduced host defence that comes with immunosuppression and other disease states. Patients may be septic with fever, rigors, or general malaise, and they commonly describe pain between the scrotum and the anus with coexisting lower urinary tract symptoms or UTI symptoms. It can also present with retention if acute, or recurrent UTIs if a chronic picture. On examination, they may be tender suprapubically or have a palpable bladder if in retention. The prostate will be tender, and the patient may flinch or exclaim when you palpate it. Everyone's pain threshold is different, so if it's not obviously painful, it's worth asking the patient as you press on the prostate, is it uncomfortable or is it painful? We often refer to it as feeling boggy or a bit sort of squidgy feeling on examination, and if it feels fluctuant, then there may be an abscess in the prostate. Investigations should include a urine dip and urine culture, full blood count, urea and electrolytes, CRP, and a lactate as a marker of severity of infection. If the patient's febrile, then blood cultures should be taken in line with your sepsis 6 pathway. A bedside bladder scan should be performed after the patient has voided to assess whether they're retaining urine, in which case they should be catheterised. These patients may be septic, so your initial management should be resuscitation with an A to E approach. I won't go into detail about that now. Ultimately, the patient needs antibiotics, which should be delivered in the first hour if they're septic, and this should be guided by previous sensitivities and your trust's microbiology advice. Traditionally, the go-to antibiotics for prostatitis are quinolones, such as ciprofloxacin, as they have good penetration to the prostate, and we would give an extended oral course of 4 to 6 weeks on discharge. This has fallen out of favour a bit because of an increased risk of aortic dissection, aortic aneurysm ruptures, and tendon rupture with prolonged use of fluoroquinolones. So depending on the patient's individual risk and the way that you counsel them, we may be more inclined to give a broad spectrum penicillin such as coamoxiclav, but again this would be an extended course. Some take-home messages for prostatitis. Urological infections in men must always be taken seriously, and these patients need urological follow-up to investigate the cause of the infection. Beware the septic patient that's unwell with abdominal pain. Yes, this could just be a bad urinary tract infection or prostatitis, but always consider the possibility of an infected stone, and this should prompt you to perform further urgent imaging with a non-contrast CT of the kidneys, ureters, and bladder. Last but not least, we're going to talk about prostate cancer. Chances are you all know someone who's been affected by prostate cancer, and you will definitely encounter it professionally, so it's important to have at least a basic understanding. The first thing to say is that patients present to us in a variety of ways. Often they're asymptomatic and have had a PSA blood test as part of a general MOT. We'll come on to PSA shortly. They may have lower urinary tract symptoms, blood in the semen or blood in the urine, or an abnormal prostate on examination. Suspicious features are nodules, a hard, firm or craggy prostate, and asymmetry. Because prostate cancer is often asymptomatic in the early stages, many patients don't present until their disease is quite advanced. So they may have systemic symptoms such as reduced appetite or weight loss, leg swelling due to disease in the lymph nodes, bony pain from metastases, coagulopathy from liver metastases, or peripheral neurological defects from vertebral mets or spinal cord compression. The older you are, the more likely you are to have prostate cancer. If you're Afro-Caribbean, your risk is 1 in 4 versus 1 in 8 for other ethnicities. If your father or brother had prostate cancer, your risk is around 2.5 times higher. And if you have BRCA2 and to a lesser extent BRCA1 gene mutations, then you have an increased risk of prostate cancer. So it's worth inquiring about a family history of other cancers such as breast, ovarian, and pancreatic. All patients should have a blood test for PSA, prostate-specific antigen. This is an enzyme produced by the prostate to liquefy the semen. It's prostate-specific, but it's not cancer-specific, so it can be raised in lots of other things that affect the prostate: infection, retention, catheterization or instrumentation, if the patient has ejaculated recently. If they have a large prostate, then more PSA will be secreted, and as well as those, it can be raised in prostate cancer. There are age-specific normal ranges, and the PSA should always be considered in the context of the patient's history, examination, and DRE findings. Multiparametric MRI of the prostate has come to the forefront of diagnosis in the past 10 years or so. Almost all patients who are fit for curative treatment will have this done. Not only does it help with diagnosis, but it also gives us information for local staging and planning of surgery. Remember that in order to treat any cancer, you need to grade it and stage it. Grading gives us information about the aggressiveness of the cancer by looking at how abnormal the cells are microscopically. We can obtain tissue from the prostate via a truss biopsy, transrectal ultrasound-guided prostate biopsy, or a transperineal prostate biopsy. Truss biopsy is more commonly performed, and this involves an ultrasound. Remember that in order to treat any cancer, you need to grade it and stage it. Grading gives us information about the aggressiveness of the cancer by looking at how abnormal the cells are microscopically. We can obtain tissue from the prostate via a truss biopsy, transrectal ultrasound-guided prostate biopsy, or a transperineal prostate biopsy. Truss biopsy is more commonly performed, and this involves an ultrasound probe in the back passage through which biopsy needles are passed to obtain tissue. This is performed under a local. Remember that in order to treat any cancer, you need to grade it and stage it. Grading gives us information about the aggressiveness of the cancer by looking at how abnormal the cells are microscopically. We can obtain tissue from the prostate via a truss biopsy, transrectal ultrasound-guided prostate biopsy, or a transperineal prostate biopsy. Truss biopsy is more commonly performed, and this involves an ultrasound probe in the back passage. Moving on to staging, this looks at the extent of cancer or cancer burden, and like most cancers, we use T&M staging. You wouldn't be expected to know this in great detail. The key points are just that T1 is non-palpable disease, T2 is palpable but confined within the prostate, whereas in T3 there's spread outside of the prostate, and T4 is where adjacent organs are involved. N1 signifies regional lymph node involvement, and when we get to M, we're looking at metastatic spread to non-regional lymph nodes, bone, or visceral mets, such as in the liver or lungs. MRI can give us information on the tumour and regional lymph nodes. The picture on the left shows an organ-confined or T2 tumour, and on the right we have a rather nasty, locally advanced T4 tumour with some bladder involvement, which you can see by the left-hand arrow, and rectal involvement, which you can see on the right. We may also arrange. MRI can give us information on the tumour and regional lymph nodes. MRI can give us information on the tumour. MRI can give us information on the tumour and all cancer patients should be discussed in the appropriate multidisciplinary team meeting. It's always worth mentioning that in an OSCE situation. Our MDT consists of urologists, oncologists, radiologists, pathologists, specialist cancer nurses, and there may be clinical trial nurses as well. The aim for the MDT is to confirm the histology, determine the need for any staging investigations, and identify the most appropriate treatment options. Management options are varied and don't always involve eradicating the cancer, as all treatments have risks and potential side effects, and these may reduce the patient's quality of life. So it's about creating a balance really between extending the patient's life expectancy and giving them a good quality of life as well. Active surveillance aims to avoid treating indolent, lower grade cancers by only treating if there are signs that the disease is progressing. So this is suitable for medically fit patients with a good life expectancy and localised disease. So, for example, a 50-year-old man with a very small focus of low-grade prostate cancer, putting him through a radical operation or radical radiotherapy may leave him with unwanted side effects such as erectile dysfunction and incontinence, when actually this prostate cancer may not progress to anything more, or at least he could have another 10 years, for example, or longer with a good quality of life before requiring treatment. So these patients undergo monitoring with PSA blood tests, regular digital rectal examinations and MRIs to regularly look for evidence of progression. And at that point, the patient would be reinvestigated. Watchful waiting is for patients who are not fit for curative treatment. In these patients, we can offer them treatment to control the disease rather than cure it if they're developing symptoms or if they develop evidence of metastases. Radiotherapy is offered for local and locally advanced cancer and can also be used to palliate painful bony metastases. Surgery can be offered with the aim of cure, so this is for organ-confined disease. Radical prostatectomy can be performed through open surgery, a laparoscopic approach, or robotic assisted, and often will remove lymph nodes at the same time. We can also manage prostate cancer through hormone treatment, which works on the hypothalamic pituitary axis, and the aim of that is to reduce a patient's testosterone. Chemotherapy is reserved for metastatic disease and also in those who may become resistant to hormone treatment later down the line. In all cancer management, the role of the cancer nurse specialist is vital. Patients often see numerous doctors in various specialties, and the cancer nurse specialists are more of a constant throughout their whole journey, and they can help with the psychosocial aspects of things as well. The take-home messages for prostate cancer are that prostate adenocarcinoma is now the most common cancer in men in the UK. The PSA blood test needs interpreting with the history and examination findings, and you can't rely on your PSA value alone. Not all prostate cancers require radical or curative management, and that all cancers should be discussed in the multidisciplinary team meeting, and all cancer patients should have an assigned cancer specialist nurse. So that was a whistle-stop tour through the prostate and some common prostate diseases. A lot has changed over the past decade or so in how we as urologists treat BPE and prostate cancer in particular. So it's a really exciting time to be a urologist. And urology is a great career because it's a good mix of medicine and surgery. And the surgery takes a lot of different forms, as we've mentioned today, varying from minimally invasive to big open surgery. We're generally a very friendly and approachable bunch of people, and we like to get medical students and junior doctors involved. So if this sounds appealing, then please do consider a foundation job in urology. We'd be glad to have you. So thank you for watching, and I hope you found it useful today.